Hi, Dana and Catherine. Can you guys hear us?
Yes, how are you?
We hear you great. Okay, awesome. Catherine's there too.
Your boss is here.
Good.
There's Skip.
Oh, hello. I know you
I
have
can't,
to. Why
I
aren't you?
can't, I can't see you. I'm just looking
Oh,
at a screen
wait.
that says myositis. But I know whose voice that is.
Yes. Can you see us now?
No.
Maybe you don't have the camera on. Just proving this is not a procedure-oriented specialty.
Oh, okay. All right. I see
Dana
it.
Dorenzo's hands. I can see
Hello.
you. Hold down the fort.
Wait, now I
Glad you
gotta
guys
do-
joined without too much difficulty.
Hello, how are you?
Good, how are you?
Good. I saw all the hiking pictures today. I was so jealous.
No, she can see now. I'm not sure how wide angle it is, but can you see Deedham in the picture, or is she out of your view shot?
No, I don't see Dino.
Okay, so it's probably really just Rachel.
That's what I was.
Chris, I'll put the notes in Google Drive.
What's up, dude?
I'll put the notes in Google Drive.
Oh, great. Thank you.
Hey, Dana, my co-fellow.
Hello, how are you?
Good,
How are you feeling?
I'm good. We just found out that someone tested positive for COVID-19 in the conference, so masking.
That's okay. Oh.
I just wanted to see if Helene and Maylene are on, but no.
Aha, there she is. Eliane, can you see me? Hear me? What time is it there? Now we have Helena Mullen. Yeah, Team Sweden is here. Korea is not here. No. I think anywhere in this area.
It's me. Hi, everyone. Hi,
Let-
Kathy. Hi, Dana.
And there's Mullen. Hello, hello.
Hello.
Yes. I'm flattered. You want my photo. So after all the photos that were taken. It's a quality 6 though. A quality 6.
Will you take the photo when my yes, she's yeah. Okay. Should I? I'm not sure if I should.
Vicky Worth joining the meeting. It's a pen avalanche. Vicky Worth. Worth.
Yeah, yes.
Hello.
Hello.
Can you hear us okay?
Yes, I can.
Perfect. Welcome, welcome. Great to have you.
It's great to be here.
All right, we're going to get started in 1 minute. Vicky Worth. Vicky's here. Repping strong, you Penn. Vicky. The one and only.
Who all is there?
Can I oscillate the camera maybe? We'll do
Oh, that's
we'll pan for a second.
hey.
This is nice. This is what I do. I'm gonna kind of leave in the middle and we'll see what goes on from there. All right, should we get started? Yeah. Oh, sorry, you okay?
Yeah, I'm good.
You okay? You want to stand? I think, or-
I think I'd like to stand.
Okay.
Some time.
Yeah,
But I'll stand later when Lisa's finished, but I just get prepped to get.
sure. All right, if it's okay with everybody, I think we are going to start. Hold on. Let me just admit a few more people. Yeah, if you don't mind, if people pop in. Yeah, there's a waiting room. Okay. Everyone can hear me okay?
Yep.
So welcome everyone to the Myositis SIG. Appreciate you coming. My name is Chris Meckley from Baltimore in the United States. I'm one of the members of the working group. You can see I'm accompanied by several colleagues who will introduce themselves momentarily. And we're also joined online from across the globe. Doctors Dana Dorenzo, Helena Alexanderson, Marlon Regar, and our PRP from the US, Catherine Sarver. So I just wanted to frame the next hour and a half of what we're going to be talking about and just brief overview of the agenda, which is right here. And bear with me, a little sensitive. Okay, great. So in a second, I'm going to turn it over to Lisa Christopher Stein, who's going to kind of just provide a brief overview of our SIG work to date. We've been around for a while, since 2011. So it kind of helps to have an idea of what we've been doing to understand what we're going to be talking about here today. From there, we're going to turn it over to our PRP, Ingrid Tagut, B- on the pronunciation. Okay, who's going to just describe her own experiences in working with our SIG. And then from there, we're going to turn it over to Didem, who's going to talk about the methodology and results, specifically the characteristics of the instruments that we're going to be talking about: responsiveness, discrimination, MCID. And the big picture goal of what we're trying to get out of you today is basically the role of a peer reviewer. We're going to present methodology and results. First, look at the data, OMER Act exclusive, and we'd love to hear feedback about what we did methodologically. What do you think about how we interpreted the results, and just hear your thoughts. Throughout the time, we have some discussion questions that are built in to kind of facilitate that conversation. So with that, let me go and pass it over to Dr. Christopher Stein.
Hi, everyone. Lisa Christopher Stein, also from, thank you, Baltimore in the US. And I guess I'm the oldest member, one of the oldest members of the group, the longest standing member. So I have been given the task to tell you in 6 minutes what we've done in the last 12 years. So here we go. This is the group, which on the left are our wonderful patient report, our PRPs, and Ingrid will follow me. Catherine Sarver, as you heard, was online. Our OMERAC fellows, Deedham and Dana. Dana is also joining us virtually, and Deedham will also follow in just a few minutes. The co-chairs of the session, in addition to myself, are Chris, as well as Helene Alexandersson from Sweden, and Jin Park from South Korea. You may wonder, as you saw the initial slide, how it is maybe that co-chairs come from Sweden and South Korea of all countries. And it turns out that we were told when we assembled the group that we should represent different parts of the world. And we hadn't really thought about what it meant to choose 2 non-English speaking countries as part of that 3-person group. But those were 2 countries that had large myositis populations. And it turned out to be amazing because we learned a lot from each other. And the difficulties that is that when you try to do this work in multiple languages and multiple cultures, but I think it turned out to be one of the best surprises and the most important things that we did. And it was really sort of a little bit of a beautiful accident to do so. On the left are the rest of our working group, which again represents Sweden in addition to the Netherlands and Australia. And we also include neurologists in our group as well. And then we have Dorcas and Laura who are here, and our fearless leader who began to really tell us about the importance of needing this work, which is Bing Bingham. A very brief review for those of you who don't think about myositis. And when you think about myositis, you might think about myo, the word muscle, itis, inflammation, and you must think, well, this has something to do with muscle inflammation. And it does. And how that usually manifests itself is weakness. Interestingly, we were discussing that myositis was taught, at least in medical school in my day, to be a painless weakness. And it turns out that if you ask patients, in fact, they have a fair amount of pain indeed. In addition to the muscle, it can also affect the skin, the lung, the joint, as well as sometimes even the heart in an inflammatory fashion. And so we recognize that this is a multifactorial patient experience. It's both physical and psychological. And so really we did not have the benefit of a scoping review of, I don't know, 10,000, 8,000 papers. In fact, everything we had in the patient reported outcome measure or PROMs was borrowed from other disease states and developed completely in the absence of significant patient involvement. Often there was no patient involvement whatsoever. So this gave us the opportunity for this idea of a patient-physician partnership. And this is essentially on this slide, what you'll see over time that was the result of a lot of work, including deriving these patient-reported outcomes by rigorous methodology, literature searching, multiple Delphi surveys, and this was across the world. And Ingrid will tell you the scope of the Delphi and how far we reached. And then, of course, content and face validity and criterion and construct validity were also assessed. And in addition to developing our onion, we then went on to develop candidate instruments which you'll hear a lot about today, including pain interference, fatigue, and physical function, which were all from the PROMIS instrument perspective. So I did before this what any self-respecting researcher does, and I asked ChatGPT, so tell me about myositis from the patient's perspective. I don't know, did they get it right? So I wonder how much of this is actually informed from the work that we did. But some of the things that came out of that were, true, there's a range of symptoms, right? But ChatGPT knew about pain and fatigue. I will tell you that most doctors didn't before we started this work. We really did not appreciate that. And it significantly impacts the quality of life, and the symptoms vary widely patient to patient and in its severity. And then, of course, it's important to work closely with your healthcare team. And I could not be more proud to be part of this team. So I told you it was 12 years. We started back in 2011. And our very first meeting was in Pinehurst in 2012. And that's when our SIG was established. And the goal at that time was to develop a set of core domains and respective measurement instruments that capture the experience of living with adult myositis from the patient perspective. So we didn't include children, and we didn't include inclusion body myositis, which is one subtype of myositis that seemed to be very different than dermatomyositis, polymyositis. And those of us in the field that treat myositis patients know that we've moved beyond those, including immune-mediated necrotizing myopathy and the anti-synthetase syndrome. So essentially anyone with myositis that did not include inclusion body myositis from the patient perspective was invited in to participate into our work. So that initial qualitative work from that SIG investigated which aspects of health were important to our patients. And over a 3-year period, 11 focus groups were conducted. Those were in 3 countries. Again, you'll see it: Sweden, the United States, South Korea, to understand the patient's experience of living with myositis. And you'll see this abbreviated as IIM, which is idiopathic inflammatory myopathy. We then move on to 2014 into Budapest, and then our preliminary results first underscored the importance of patient input in the development of patient-reported outcome measures to ensure content validity. And then results from multi-center focus groups indicated that the range of symptoms initially in our initial survey included pain, fatigue, impaired cognitive function, which were not known or currently assessed as part of the myositis construct. We further refined these, and you'll see over time. I wanted to remind you that myositis is a very rare disease. On average, we think 1 in 100,000 or 10 in a million patients. So compared to rheumatoid arthritis, it's about 1,000 times less common, yet we were very proud to have 643 patients involved in their initial Delphi surveys. So United States was well represented, including Sweden and South Korea. What we learned here is that all we asked patients to do is tell us what's important to you. And it turns out that patients thought everything was rather important. And so we learned and refined this. And over time, we went from asking for what was important to ranking that importance. And we gradually were able to whittle down to what you'll see today as our core set. So during OMERACT, the top 5 rated domains then were muscle symptoms, fatigue, interaction with healthcare, medication side effects, and pain. We discussed that we needed a further reduction in the number of domains, and then our goal in Australia in 2018 OMERACT was to present and seek voting on a myositis preliminary core set. A few things that we learned along the way was that if you ask healthcare providers, which we did, so we decided to involve further stakeholders, and we thought it was important to not only ask patients but also ask the people who treat them. And the differences were pretty significant between the way the patient saw the disease and the way that healthcare providers thought the disease was manifested. But what didn't vary is across the world, in multiple countries, the patients' ratings across the world were remarkably similar. So we were convinced that we were adequately representing the patient experience across the planet and not just in a few places. So by 2018, the domains of muscle symptoms, fatigue, level of physical activity, and pain all reached greater than 70% consensus, and we felt were mandatory to assess. I would be remiss not to mention that of the OMERACT myositis, of the OMERACT core sets, we focus specifically on life impact. And I recognize that's a little untraditional in the myositis world. And the reason that that was done is that the other features, including pathophysiology, death, were already being investigated and were done by IMAX. And IMAX is the International Myositis Assessment and Clinical Studies Group that had previously done this, and there was felt to be reduplication of efforts. So we drilled down to life impact with our PRO. Again, you can see our onion, which includes the mandatory fatigue, eventually pain interference, and then physical function. So after many Delphi, multiple times, multiple voting, we came down to those 3 mandatory domains. The instrument selection for that, as I mentioned in the beginning, was the PROMIS pain interference 6A, PROMIS fatigue 7A, and PROMIS physical function 8B. And we further assessed content validity of our PROMs and then reliability and validity of our PROMs as well. I just want to make a special shout out. We were speaking about inclusion in different languages, and I think, and so as part of the OMERACT framework, to try to make sure we reach everyone. And I couldn't be more proud to work with and have Ingrid be part of our working group. This is actually a first authored publication by Ingrid in the Dutch Journal of Rheumatology in June of 2019. She did have to translate for me, but and she'll tell you a bit about that work in just a moment. But it was OMERACT myositis SIG, searching for patient-reported outcome measures together with patients. So we really can work together, and our patients play a very integral part of everything that we do. There we were at the poolside. Well, Ingrid makes sure her muscles felt good in the hot tub. We worked side by side, and we aim to accommodate. So I will now pass it over to Ingrid, who will tell you a bit more about how PRPs matter. Can I get it for you? You go, sure.
Yeah, I only have one because I have to hold the mic.
Oh, you okay to stay?
Yes, I am. Thank you. Yep. So I do some exercise in the meantime. Hi, everyone. So my name is Ingrid de Groot, and I'm the patient research partner for this Myositis group. And I very much appreciate you coming here today. I will be talking to you on behalf of the two patient research partners. The other one is, as Chris mentioned, Catherine Savers. She's joining us live from the US in Maryland, I think. Hi, Kathy. She's waving. And so Catherine is my patient research partner, so to speak. And what I want to do today, because Catherine and I have been to previous OMERACT 6, and there we presented our story of living with myositis. And today, since we're doing a different kind of SIG, we are focusing now on the role and the impact that patient research partners can have. So that's what I want to talk to you about today. And I want to say that I'm so grateful to be part of this OMERACT myositis SIG. And I know I'm a bit biased maybe, but it's the best group there is. So, okay. So to role of PRPs in the instrument selection. So at the very beginning, we played an important role in interpreting the many domains mentioned in the focus group. And I remember in 2016, which was my first OMERACT, Watson Whistler, I didn't know anyone of the group. And we had a meeting where I had to get used to, like really late in the night. And we were talking about this list of domains and how they were overlapping, etc. And I remember that there was a lot of patients mentioning trembling, shaking, etc. And what I noticed, and actually that was my first action ever for the OMERACT, that the clinicians sort of automatically assumed that we were talking about tremors then. And I thought from my personal experience that when I am really tired, my muscles start shaking. So, and that's what Catherine said too. So we thought, well, maybe it's not so much of a tremor. I'm not a clinician, but to me, it's more like muscle fatigue or muscle endurance sort of thing. So, and then I knew that I could make a difference because I was very uncertain at the moment. And I thought, okay, I'm good here. So our experiential knowledge was indispensable also in assessing specific qualities and characteristics of the PROMs. Now, pain has been mentioned a lot this week and the difficulties around pain. And are we talking about pain interference, pain frequency, pain intensity? And from the stories that Catherine and I shared and that the clinician recognized from hearing from patients, we decided to focus on pain interference. So another thing we did was we formulated working definitions of domains. So what I did is I drafted like that was a starting point for discussion. And it's really nice to work that way because I hear of other PRPs in other groups that sometimes that work is done and then discussed with patient research partner if they agree. And we sort of did it well the other way around, or at least we collaborated a bit more on that. So then there's the domain, the muscle symptoms that Lisa was talking about. And our group considered the possibility that this may be encapsulated by the other three domains. So the pain, the fatigue, and the physical function. And to obtain further clarification on it, we distributed a survey to patients in multiple countries. And here, Catherine and I, as patient research partners, we had a role again. So we helped developing the survey. So to make it more inviting and patient-friendly, that was one part of it. The other part of it was that we distributed it and shared it with other patients, with our networks or respective patient associations. And the networks are growing like, I don't know, they're really growing fast. And that helps us also, as Lisa was saying, with the Delphi's, we got the patient community involved through respective associations. And that resulted in over 500 patients in more than 40 countries, which is, I think, is amazing for such a rare disease. And it shows the impact that patient research partners can have. So I think that's about it. Thank you.
You can go next, actually, but let me see. Okay. Hi, everyone. I'm Deedam Sagan. I'm the lucky fellow of the Myositis Working Group. I work at University of Pittsburgh. I'm a rheumatologist. So today, in the next 10 minutes, I will be focusing on the methods that we used in the responsiveness and clinically meaningful thresholds of PROMIS pain interference, fatigue, and physical function form in adults with idiopathic inflammatory myopathy. So our aim with this study was to assess the responsiveness and clinically meaningful thresholds of the PROMIS instruments, pain interference, fatigue, and physical function. I'm sure everybody knows what responsiveness means, but just to have everyone on the same page, responsiveness indicates the ability of an instrument to be able to detect the change. So if a patient reports improvement, we expect a good responsive instrument to be able to detect the improvement. If a patient gets worse, we expect that a good responsive instrument should be able to detect this worsening. So we enrolled adults with diagnosis of idiopathic inflammatory myopathy according to the 2017 EULAR-ACR myositis classification criteria at 5 international study sites in the outpatient setting from Australia, Netherlands, South Korea, Sweden, and US. This was a prospective observational study with 2 study visits. All the patients provided informed consent for participation, and the study was approved by the local IRB at each participating site. The PROMIS instruments were already translated and adapted for the local cultures in English, Swedish, Korean, and Dutch. That's one of the strengths of using PROMIS instruments, actually. So at baseline, we have obtained, again, these are our PROMIS instruments of interest. And in addition to that, we have obtained information on myositis outcome measures. So these are considered to be the core myositis, core outcome set, I guess, core myositis core set measures. The manual muscle testing, physician global disease activity, and patient global disease activity. So at the follow-up, we collected all the same information, PROMIS instruments and myositis outcome measures, but we also had 3 separate symptom-specific anchor questions that we asked our patients. Just to give a little bit of information about the outcome measures that we've collected, first one, the manual muscle testing. It's performed routinely in the clinical practice of patients with myositis to assess the muscle strength. We've used MMT-8 in this study, which means we assessed 8 separate muscle groups and scored the muscle strength from 0 to 10, 0 meaning very weak muscle with no contractions felt, and 10 being the muscle that can hold its position against strong pressure. So the total score ranged from 0 to 80, with higher scores indicating better strength. We also collected information on physician and patient global disease activity. I'm sure everybody is familiar with this. This is pretty similar to the other diseases. It's scored on a visual analog scale from 0 to 10, and higher scores indicate higher disease activity. The recall period of this instrument is 1 day, and you can see here how we asked the physician global disease activity and the patient global disease activity in the clinical practice. The next is the PROMIS instruments. So PROMIS indicates, again, patient-reported outcomes measurement system. It's an NIH roadmap initiative to develop robust and precise patient-reported outcome measures for use in clinical practice in clinical trials. So for pain interference, we have used short form version 1.1, pain interference form 6A. So 6A means there are 6 questions in the questionnaire. So the output that you get from the PROMIS scores are actually displayed, usually used as T-scores. So the T-scores are derived from a large sample of people with healthy people. So the T-score is considered 50 for the general population, and one standard deviation is 10. So if someone, let's say, have a T-score of 70, this means that they are 2 standard deviations above the general population. The recall period is generally 7 days. And here you can see the questions that are asked in the pain interference 6A form. Next one is the PROMIS fatigue. We used the short form version 1, fatigue 7A, which included 7 questions. And the physical function form was version 2, physical function 8B. And here you're seeing 8 questions that are included in this questionnaire, basically asking the patient their ability to be able to do daily instrumental activities, basic and instrumental activities. So the next, we obtained anchor questions. Again, these are separate questions for each domain. For pain, we asked, since your last appointment, has your pain gotten a lot better, a little better, stayed the same, gotten a little worse, or a lot worse? In terms of the statistical analysis, so we first focused on the responsiveness of the PROMIS instrument. So the first analysis was the comparison of the PROMIS instrument score across the domain-specific anchor groups using ANOVA. So we hypothesized that the PROMIS instrument score change would be significantly different among those who improved, stayed the same, and worsened. So this tests the ability of PROMIS instrument to differentiate these different anchor groups. The second set of analysis we've done for responsiveness was testing the significance of within-person change in PROMIS instruments using a paired t-test, effect size, and standardized response speed. So we hypothesized that the PROMIS instrument scores would significantly change over time in patients who improved, and it wouldn't change significantly if patients reported that they're staying the same. The third analysis we've done was we looked at the correlation between the change in the PROMIS instrument scores in relation to changes in the myositis outcome measures. So we came together and we came up with a list of a priori hypotheses that we've agreed upon, which I'll share with you. So in summary, we expected that there would be a moderate correlation between the PROMIS instruments, pain interference, fatigue, physical function, and our myositis outcome measures of disease activity and muscle strength. And the next we tried to determine the clinically meaningful thresholds of these instruments. Our goal was to calculate minimum clinically important difference, MCID, which is defined as the smallest difference in score which patients perceive as beneficial or worthwhile. We used the anchor-based method and calculated the change reported by the patients, the change in the T-score that corresponds to a one category shift to achieve a little better or a little worse. So that was basically a summary of all the analyses that we've done for this work. I guess we're gonna stop here to see if there are any questions.
You're wonderful. Thank you so much. I'll just take this one. So in a minute, we're of course going to move on to presenting the actual results, but we wanted to have a pause here just because it's been a while, but also to solicit feedback, comments. What do you think about the methods employed? Are there additional analyses that we should be considering? Or if not, we can move on to the results, but I imagine there might be. Please, yes. Oh, wait, sorry.
So I think you've employed sort of standard methodology for some of us who agree that this is the way to measure important change. And I have always been an opponent of this method because I always felt, you know, if you want to measure change, you have to put patients in a situation where they change. So that would be, for instance, patients starting on a new medication that is expected to work in at least a proportion of cases. And if you don't have that, and you do this anchor-based method, which is widely in use, I mean, you'll get results and you get them published and everything's going to be fine. But the principal problem of this is if the population does not change, you're looking at the extremes and you're using this anchor, which may be just as good, worse, or slightly better than the instrument you're testing. So now you're testing correlation between things that are sort of indirect. And you know, if the correlation is really good, you could say, why are you developing the instrument? Because the anchor is good enough. And if the correlation is not so good, then you don't know why that is, whether A is better or B. So I always feel, you know, measuring change has to be in a population that changed, and measuring non-change has to be in a population that is expected to stay constant. That's just my longstanding view on
That's
this.
a good-
Sorry to impose this on you.
No, that is a good point, actually. Yes. For example, if you were to have patients with newly diagnosed disease, you know that they have active disease, and you know that after starting treatment, they are expected to improve, and that would be the ideal scenario to calculate the clinically important difference.
I'll just add as well, we neglected to mention, but we did try to enrich the population for new patient visits to address that very issue, but it's a great point.
Hi, Peter Merkel from the University of Pennsylvania. I think I've been to every myositis SIG since the beginning of time. So, and it's been really nice to see your progress and all the amount of work you've done and the growth and also retention of your members. So it's very impressive. I have 2 points. One point is it really what you presented as the myositis core set? It's not the myositis core set in my mind. It's the myositis core set for life impact. I would be careful about the terminology. Myositis core set should be everything. And I think that you made a good argument for why you should bring in the ICMAX, MUXMAX, whatever the IMAX measures. So why don't you just do that? Why don't you bring them in, have a core set that includes all things, help the IMAX people understand the OMRAC approach, help you understand that approach, because what you're doing is a core set, but it's not the core set. And I think you should think about that. Which brings me to my second point, which is, can you maybe go back a slide or two? What I'm going to say, I don't want to say myositis measures because they're all myositis measures. What? Yeah, no, go one forward, measures. You do. Okay, right. So you have what are the measures you're doing in the data collection that you're going to show us? Do they include the IMAX core set measures?
So there are 6 myositis core set measures, and we're including 3 of them in this study. And those core set measures were determined by the IMAX group.
But you don't have some of the CROs, is that correct? Clinician reported outcomes.
So the physician global.
Physician global, but you
essentially
don't,
is
and
the
it's
only-
manual muscle, but you don't have the full set. The reason I say that is, in the end, we like to keep the CT and OMRAC. You want to be able to put this into a clinical trial. In the end, it's important to understand the relative contribution of each measure. Is the measure complementary? Is it redundant? Maybe the clinician reported one is redundant. But if you don't have them all together, you can't see the directional change versus one another, and you can't do item reduction, which is going to have to happen, because I looked at protocols and helping design things, myositis, there are a lot of measures. So I think that is an opportunity to consider as you move forward, because developing these in isolation is going to end up with a very long list of things, and you won't know. I anticipate that these will be complementary, not fully overlapping, but they won't all be. And the clinical reported ones will also not be. So that's my thought.
The IMAX core set, or for the other measures of the myositis core set, they are not, there's no other physician reported just the extramuscular. Oh yeah, it's true.
Okay.
That's one more is extramuscular global. There is one. And then there's CK and extramuscular CK hack. So there's the hack, everything other is patient or a marker or.
Well, the hack could certainly be overlapping. It would
guess
be
the extramuscular
intriguing
global.
to know if the CK, I mean, they're in there for a reason. And I think it would be good for you to see. It's also interesting to know what correlates. I just think I would advise or suggest you consider one of the goals to be how's this going to look on a protocol in 2025? Not to mention the point that I make in every meeting now is, will it be acceptable to regulatory agencies as an approvable outcome? And that is a high bar that we don't talk about enough here.
So my question is related to responsiveness. We know how important, the anchor itself, it plays a role, and what you answer, what you get. So my question here with your anchor, did you ask a global change in disease activity, or did you anchor it, you had separate question for fatigue, for pain interference, and for each domain?
So it wasn't, since the last appointment, are you feeling any better? It was specifically, has your pain gotten better? Has your fatigue gotten better? Exactly. Oh, go ahead.
So I think I completely agree with the point that was made about regulatory acceptance, and there's so many things that come to mind. One question that I did find myself thinking about was, how did you select certain versions of the instrument? So, for example, why the physical function 7B instead of let's say promise physical function 20A. So I think there is a paper published on I think the promise physical function 20 by one of the contributors to the IMAX. So I'm just curious, and the reason why I asked this question is that, first I commend you in the number of patients you were able to include in the exercise, because from a regulatory standpoint, that will be key. But I do think that with the work that the IMAX is doing and the work that you've done, it'd be wonderful if these forces can sort of come together, because eventually from a regulatory standpoint, the challenges with all of these measures will be evidence of patient relevance and clinical meaningfulness, and ability for the composite to capture how patients, quote, feel, function, and survive in FDA's words, for example. So I think those things would be really important. And while I think that assessments of quantitative aspects of the measurement properties are certainly very important, but content validity evidence, without content validity evidence, the rest will be irrelevant to regulators. So I would also ensure that the content validity with evidence of saturation is established for each of the patient-reported outcomes as well.
Great points you made, yes. So I would say Lisa has summarized probably a decade of work has been done on the content validity aspect of this. So we've done several focus groups in several different countries. And what basically has been done is, after we decided on the domains, the 3 domains of interest, then we've done a literature review and came up with a list of instruments that can capture these domains. And then we did focus groups and gave these questionnaires to the patients, and then got their opinion. Do you feel like this is relevant to what you're experiencing as a myositis patient? So based on that work, that's how we came up with these instruments. One other aspect that was important for us was being available in the languages that we're interested in. So if it was available in all the languages, then that was another reason. Go ahead.
Yeah, I was just going to echo that point. So even if we got to one instrument, we recognized that there were some, I think it was Dutch, that it was not, I remember correctly, one instrument just wasn't available in Dutch, and that was one of our larger groups for which we have participation. So it had to be inclusive of the languages for which we asked. And we asked direct patient participation, including our patient research partners who were directly involved, and said, this seems to be, so there was overlap, redundancy. The other thing that came up in my mind was like feasibility, the fatigability to have they didn't think a 20-point scale was better than a 6-point scale sometimes. That specifically got discussed. They said they did not think, I mean, you can speak to, I don't want to speak for you, but we had intimate discussions when we couldn't necessarily see the difference between those instruments. It was them. I remember exclusively saying, well, Catherine and Ingrid in particular, and then other patients, but they first said, well, I can't myself as a patient see the difference here. And why would you ask this? This is a problem where people choose the instruments often for patients and say, oh, but there are more questions. You want to ask more questions. And they thought the exact opposite, that they felt it was redundant and fatiguing as the 2 things that I recall. I don't know if you want to speak more to that.
No, you said it all. Yeah.
I think one of our challenges as we move forward in this therapeutic area will be now. So we have now evidence of relevance of 3 measures of physical function, for example, right? We've got the HAC, we've got the promise physical function 20, and now we also have the 7B, which is great. But I think eventually we'll have to, as sort of the scientific community in general will have to sort of narrow down into
Right.
what makes it to the core set measure.
Exactly.
Promise by nature of having an additional response option is likely more sensitive than the hack. But I suppose that's not surprising, but
Right.
yeah.
It's also just worth noting that in the cognitive debriefing we did with these instruments, we asked about the hack DI and they're like, this isn't really relevant to me. Some of these questions don't really apply to me, which we published as well. So that was also
So some of my questions relate to physician global disease activity assessment versus patient.
Mhm.
And I wonder if it's concordant or discordant. Because I generally don't trust physician global assessments because physicians are really bad at it generally, and they actually don't ask patients very, very well about what's going on. And if they're discordant, I would go with patient global disease activity as opposed to physician. And actually, a number of the questionnaires that have come over time, they went from physician focused to patient focused with regard to their condition. So generally, because I try to minimize the number of questions and so forth in programs, unless they add sufficiently, I would get rid of physician disease activity. The second part is, can you go to the previous one with regard to, so manual testing, I think is useful. You had the whole list of outcome measures. Could you go to that slide? Thank you. So first question I have is, did PROMIS work? Was it sensitive to change?
We'll
Okay,
go over this, yeah.
because to me, whenever I've used PROMIS, it's always been a broken promise. And then what else?
Yeah, don't give us details on that, Joe.
Yeah, I know. All right, so I'll stop there. But I
Let me
think
answer that about physician.
I just said most of the time when I've used PROMIS, it's been a broken promise.
So in terms of physician patient, let me answer that and then we'll come to you, Bing. So we've done studies on that. Again, this is totally separate from the PROMIS work. So about 30% of the patients, there is discordance between what's reported by physician and patient. Discordance meaning at least 2-point difference between physician and patient reported global disease activity. And when you look at what's driving this difference is, it's usually the patient global disease activity correlates better and is derived more by fatigue, pain, and quality of life compared to physician, which is mainly driven by muscle enzyme, muscle strength. We think they bring in different information. So that's why both of them are part of the myositis core set measure rather than, just excluding one. Mm-hmm. That's a great question. Yeah, we haven't looked at that, but that's a very interesting question.
wonderful. This is very useful. Thank you, guys. Unless there's strong objection, do you have one last comment? Okay, so let's go through the results and then we're going to open it up again. And last comment.
In the middle. I was just going to say that's a great point, and I think more reason where I hope you can reach out to the IMAX group as well. So the IMAX total improvement score has 3 ClinRos, the MMT, the MDAAT, and the physician global. It has 2 PROs, HACDI and PTGA, and a lab enzyme measure. And the ClinRos carry a heavier weight than the PROs. So by definition, the physician global assessment will carry a heavier weight than the patient global assessment in that composite measure. I don't agree with it. but that's what it is.
Yes.
So
I published
more
on that.
reason, based on your comment, I think more reason for you guys to reach out to them.
No, so we are an IMAX group, actually. We are an IMAX group. OMERACT is under IMAX, but we'll talk to you about that.
Point well taken.
Yeah. So here is the baseline characteristics of the participants. So we enrolled 114 patients from US, Sweden, South Korea, Netherlands, and Australia. You can see the distribution from different countries. The median age was 60, and about 60% of the participants were female. The interval between the baseline and follow-up visit was around 150 days, about 5 months. And here you're seeing the baseline scores on the manual muscle testing, physician global and patient global. So we can say this was a population with mild to moderate weakness and disease activity. And in terms of the PROMIS instruments, these patients were definitely experiencing more pain interference, fatigue, and disability compared to the general population. So here's the distribution of the anchor questions that we asked. About 40% of the patients reported that their pain, fatigue, and physical function stayed about the same at the follow-up visit. And about 30% of the patients said they have actually gotten better in terms of their pain, fatigue, and physical function. And about 15% of the patients said their pain, fatigue, and physical function have gotten worse during the study. So the responsiveness, the results of the responsiveness analysis, the first one is change in the PROMIS instruments across the anchor categories. So here on the x-axis, you're seeing the categories of worsened, stable, and improved. And on the y-axis, you're seeing the PROMIS instrument score. And you can see here that, again, in the worsened group, the score is clustering around on the positive side for pain interference and fatigue, a little bit on the negative side on the physical function. For stable patients, it's around the 0. And for patients who improved, it's on the opposite side of the 0, the negative for pain interference and fatigue, and on the positive side for physical function. And we can see that these were statistically significant differences between these categories. So what we're showing here is that the PROMIS instrument is able to differentiate these different change categories. The second analysis we've done is to look at the over time change in the PROMIS instruments within each anchor category. So here, the slide is all about the pain interference. The x-axis is baseline and follow-up. Each line represents one patient. And on the y-axis, you're seeing the PROMIS pain interference score. What we've seen here is that the patients who got worse and who remained the same, they did not experience a significant change in their pain interference score. But when we look at the patients who reported improvement, we are seeing a statistically significant improvement in their pain interference score. So this is at least we expected, or we wanted to see a significant change in patients who improved. Again, we expected to not see a significant change in patients who were stable, but we were a little bit surprised with the worsening result because we thought the pain interference score would also get worse significantly. But again, in terms of what's the reason for this, maybe because we had fewer patients in this group who got worsened, or maybe some of the patients already started with really high pain interference score. And, you know, when you start with really high, then maybe instrument is not able to capture the worsening. So these were some of our comments, but I'm curious to hear your thoughts on this worsening group because results were quite similar for the other instruments. So in the fatigue, similarly, patients who reported improvement had statistically significant improvement in their fatigue score. And when you look at the stable, not a significant change as expected. And in the worsening, again, not a significant change in the PROMIS fatigue score. Physical function, again, same result, significant improvement in the improved group, no change in the stable group, but again, we're not seeing a significant change in the worsening group. The third analysis we've done was to calculate the effect size and the standardized response mean of PROMIS instrument. Again, another way of looking at the same thing. So here you're seeing the anchor categories, worsened, stable, improved. And we calculated the change in the t-score from baseline to follow up for each category. And you're seeing the standard deviation for each. And from those, we calculated effect size and standardized response mean. So what we expected to see was that there would be a small effect size in patients who were stable, but a medium to large effect size in patients who got better and who got worse. So what we've seen is similar to the previous results. We've seen a large effect size in patients who improved, small effect size in patients who were stable, but similarly, small effect size in patients also who were worsened. Again, this could be because, again, lower number of patients. You can see 17 patients got worse versus 45, but curious to hear your thoughts on this worsening group. Results were similar for fatigue. Again, large effect size for improvement group, small effect size for stable and worsening groups. Same for promised physical function, again, large for improved and then small for other groups. The fourth responsiveness analysis we've done was to look at the correlation between the changes in the PROMIS score versus manual muscle testing, patient global, and physician global disease activity. So we are seeing significant correlations between changes in pain interference and these myositis outcome measures, but you can see that the strength of the correlation is rather weak. So this means if the pain interference is, if the muscle strength is improving, the pain interference is also improving, but again, the strength of the correlation isn't very strong. When we look at the fatigue, we have a little bit of a better correlation between the fatigue and the manual muscle testing, as well as patient global disease activity. And you can see here, we already discussed this. There is no significant correlation between PROMIS fatigue score and physician global disease activity. For physical function, of course, this makes sense. We have even better correlation between physical function and manual muscle testing, as well as patient-reported global disease activity. So as the muscle strength improves, physical function improves. As the patient-reported global disease activity improves, physical function also improves. So, but we had some a priori hypotheses with expected correlations that you can see here. We had expected a priori that there would be moderate correlation between our PROMIS instruments and the legacy instruments. But what we observed was rather small correlation. So this means 80% of the hypotheses that we had actually were not met. So again, this will be another discussion point for us to really think through and how we should be interpreting these results. Does that mean the instruments are not good, or does that mean that we're not good at guessing what the correlation would be? So the next part is about the clinically meaningful thresholds. So this one is on the PROMIS pain interference. Here you are seeing all the granular anchor categories. So in the previous results, we had lumped the slightly worse and a lot worse and made that one category. So here we have slightly worse, a lot worse, stayed the same, slightly better, and a lot better. So what we've calculated is the difference, the change one category shift from staying the same to slightly worse. And that was, again, the difference between 0.1 and negative 2.2 was 2.3. And we also looked at the difference between stayed the same and slightly better, and that was 3.2. So we took the average and said that 2.7 would be what we would expect the MCID for pain interference instrument. For the PROMIS fatigue, we've done the same calculation. Again, just calculating the change in the T-score from stayed the same to slightly worsened. That was 3.9, and it was 4.1 from stayed the same to slightly improved. So when we took the average, it was about 4. So we thought 4 would be the MCID for PROMIS fatigue. The last part is on the PROMIS physical function. Same analysis. It was 3 and 3.6. So we concluded that 3.3 would be the MCID for PROMIS physical function form. So in summary, our study provided evidence towards responsiveness of PROMIS pain interference, fatigue, and physical function instruments in a large international cohort of adults with myositis from several countries. Minimal clinically important difference was 2.7 for PROMIS pain interference, 4 for fatigue, and 3.3 for physical function. The next steps will be involving these instruments in a clinical trial setting to assess their performance characteristics. I'm going to stop here and let you guys discuss. Here we go. Thank you.
Thank you so much, Stephen. All right, so that was a lot of data, and I'm sure and hopeful that there are going to be a lot of comments and questions to all that. So if you want to go there next, and we'll go here first.
I have a few quick questions. I'm thinking about the worsening group, and I'm wondering if you had the chance to look into the characteristic of the patient and see how many of them to start with had the ceiling. And I would expect my ceiling a little bit, not just top ceiling, but really a little bit more, because if they're majority ceiling, then as you said, there is a window for change. And my second question regarding the worsening, did you try to look into the category who had extreme worsening as opposed to a little bit of worsening? But again, I know you're limited with the sample size.
Exactly.
MCID, you showed us the anchor, the distribution, but what about the anchor-based analysis?
So that was the anchor base.
Oh, that was the anchor?
Okay. Exactly. So one category shift from staying the same anchor to slightly improved anchor.
Okay. And did you have good result on the AUCs and?
Oh, so that's the distribution method, which we haven't done. So this is just the anchor based method for MCID. We haven't done the distribution based method.
Okay. Yeah.
It's just doing the ROC.
That's
So you get a bit more of the diagnostic accuracy of how it actually does as a cut point. So you could do it with what you've got.
Hi, Gunnar Tomasson, Reykjavik. I saw on the bar graph that you showed us for scores that they were in general worsening, because I thought you enriched this population with people at first visit that might be getting steroids for the first time, and we would perhaps not see worsening exactly then, but that is what the data show, isn't it?
But it's a good point though. So flaring patient would be another type of patient that should be included in the study, but it is hard to find against flaring patient.
Was it generally getting worse, the promise scores, or were the same at the first and the second visit? Just the average? No, across one would think that across the whole group it should get a little worse, since there are more people reporting worsening. Oh, sorry.
Oh, so what you were saying? Okay,
No, see. No.
Yeah.
Sorry.
No worries.
Flipped around. So I would avoid beating you're sort of being self-critical at better correlations, worse correlations. I'm not sure that's really the adjective I would use, because if they were fully correlated, they would be completely redundant and you don't need them. And so you actually want things that are not fully correlated, because then they're providing potentially complementary information from a patient's perspective. Now, it's nice when they're somewhat correlated, because they should be indirectionally the same. But I would not be, I most would look at them as a group and seeing, does this make sense? Is this the right place? The fact that you have pretty strong correlations with manual muscle testing is interesting, and does raise the issue of, do you need both? But it's not so redundant that you wouldn't get additional perspective. So I don't think I would put it that way. I think it's good to have some things that are different. The promise, been working with promise for a long time also. Part of the point of promise is that it's already fully calibrated and it's already done, and you already have known MCIDs for promise. And I know in general. And so the question is, do you need to calculate it for disease specific MCIDs? Does it add more? I know Bing's going to say yes, because he's done this, and we've thought about this with our data as well. But it's interesting that it sort of then gets away from the idea of a measure that's workable across and comparable. Although the measures are still there, so I guess you can still compare the scores.
So I would agree with you that PROMIS has generally accepted MIDs for many diseases. It's been established, and it tends to be very similar numbers when you go from one disease to another, which gives you some confidence that that is approaching the truth. Why I say that you need to do it in the disease-specific context is because the FDA requires you to do that. Okay, they don't accept that something from another disease would be useful, especially for PROMIS scores, as we're trying to qualify a PROMIS measure right now for rheumatoid arthritis.
Yet they do an SF-36.
Yet they do an SF-36, yes. But for PROMIS, they're requiring that, and if you look at the new revision, so just FYI, the patient-focused drug development guidance document number 4
just came out.
Is a new version 2 weeks ago. It was just published. So it's worth looking at that in terms of talking about the use of anchor-based methods, the non-use of distribution-based methods, and establishing what minimally clinically important difference is from triangulation.
Yeah, I love the anchor. I think the anchor's away. It's great.
But the other piece is clinical meaningfulness is what the FDA is seeking. And all of these analyses are statistical analyses. So they're not necessarily what's clinically meaningful, but the way that you were looking at this is the amount that's clinically detectable.
I think that's the other thing is you get relatively small numbers of patients when you start breaking things down, which is always a problem in study of our rare diseases. Does that tell you that if you've got some wobbliness and some uncertainty, do you want to go back to at least a subset of people to get some more? I know the idea of getting more data is painful, but to look at a trial if it's collected, it's either a warning that it's a problem or it's just a numbers issue for you. Because these things should be bidirectional. And the lack of bidirectionality here is a little hard to understand what to make of it.
Is that
It doesn't have to be.
I was going to raise the issue, and I'm not sure that it's not covered in your question already. I was going to ask, aren't you worried that worsening does not have the same effect and statistical significance as improvement, where the anchor was totally symmetric in terms of wording, a little better, a little worse, a lot better. And then you see that almost all of the instruments do not function for worsening where they do for improvement. In fact, the worsening has the same effect as being stable. Does that worry you or not?
Yes, let's see what being
But it's quite similar. And instead of worsening, I was wondering about the stable disease group, which is larger and which is actually not stable. If you look at individual data, you have patients with strong worsening of each scale, other patients with clear decreasing. So at the level of the group, you don't see any significant differences, but at the individual level, you see strong variations. So, so does that mean? So they say they are stable, but some patients go from 70 to 40, and several of them. So at the group level, there's no difference, but at the individual level, there is a high variability. So I was wondering what does it mean? And my other point was, did you study correlation between each of the 3 PROMIS subscales?
Yes, we have done that.
And
there were good correlations among them. I guess, did you think that would also contribute to the interpretation?
Probably it's important to know if the different symptoms or, let's say, PRO domains go in the same direction in the same patients. Is there a good correlation between the different PROs?
Yeah, that's a good point. We have it. I didn't show it.
I was working with some correlation with reporting worsening with actually getting lower lower scores, but there was much greater correlation with worsening of feeling bad, of being bad. There's more correlation with claiming worsening with the state of being bad than with the change in the state. And people, we did this asking people repeatedly, and there is a group of patients that always says worse, 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 worse over, monthly or quarterly, and there is a significant group that reports constant worsening. But
of the method of aggravated where in fact aggravated say on the worsening side, not about worsening but about feeling bad. So they are interpreting what you're asking them in a different way in this problem than the negative. So it's very comparison.
I think what you're mentioning is more the like a catastrophizing for patients that have more self-catastrophizing. Is that? Mm-hmm.
I'll just say from the directionality perspective of these not being symmetric, in multiple diseases now with promise measures, this has been demonstrated. It's also been demonstrated many years ago with the SF36, with multiple domains in SF36 and rheumatoid arthritis, that there are differences between improvement and worsening. The magnitude is different. It's not a symmetrical scale. We know from qualitative work that we've done with patients in rheumatoid arthritis that there are different thresholds for what patients will say is acceptable or is a significant threshold that is very different in the direction of improvement and worsening. We've done that with promise vignettes, with bookmarking. We've shown this in multiple different ways. So this phenomenon is not, this sort of difference in directionality is not something that is without precedent.
Essentially, not the same as lack of directionality. We shouldn't some directionality.
There is directionality, but I mean, when you get to people that have a lot of change.
Right. Worsening is much stronger. So patients are much more sensitive to worsening than they are to improvement. They will tolerate less worsening than the degree of improvement before saying that it is important. So
but they are not symmetrical. Like, I don't think we should be pooling them. Now that's another one to do it by tertiles or something. Yeah.
And I found that was very, very highly dependent on where you were.
Where you started. You're right, though. They should take back deterioration. I don't know if this happened to
Yeah. If I would just suggest that if you haven't looked at, you look if it is a staple, 3 around 2 or 3 across the range of the promise.
So just if I may interrupt for a second, just so we can kind of translate this feedback into action items for our working group. So if I'm hearing this correctly, we're not throwing out the instrument because of this asymmetry. There's some precedent of why we see the stabilization from worsening and a significant change for improve, but it sounds like there's a consensus that maybe more data is needed with different analytical methods. Is that a fair statement?
And the worsened group, I think I would explore them because I agree. You've got people in the worsened group who are improving quite a bit, and it's a small group. So they're going. Yeah.
So what would happen if you actually binned the patients according to what they should be binned into? And if you use your MCID as their ruler to say what is the difference, so if they're within the 4 or the 3.2 or 3.3, and that's no difference. So then they stay within their category. But if they're past that, then they switch categories and what happens?
Okay. Yeah, that's a great suggestion.
Okay.
Go ahead.
So I think so two things. One is that I think it'll be good to kind of explore cumulative distribution function curves and kind of explore the range of the meaningful change within person, meaningful change. And I think that'll be consistent with the PFDD guidances as well, right? So and it may be that moving forward, we'll have to kind of explore that range from a regulatory perspective as well, which captures the variations in worsening and improvement and so forth. The other thing I wanted to recommend was I noticed that your anchor scales are impressions of change scales. I think it would be good to include, I don't know if it's too late for this, but impressions of severity scales. So typically, I would includes impressions of severity, sometimes even concept specific, and then include, a general PGIC, because presumably you could extrapolate the change from the severity scale. But I would recommend also including a severity scale as an anchor and not only change, because I think that'll impact your findings. Well, I wouldn't do VAS because
Although the FDA does have in their new document has
Yeah.
examples of people changing category, or changing using that as another form of anchor with ECDF as the way to look at that.
Yeah. So, well, the thing with the VAS, I think, so the anchor, as long as it matches the response scale of the instrument that you're supporting, right? So if we're moving forward, let's say with the IMAX improvement score, it has a couple of VAS scales, and I anticipate that from a regulatory perspective, we may have challenges with the acceptability of VAS scales, even though VAS scales are so well accepted in RA, for instance. But that's a whole another, we could spend a day on that. But I think it could even be general, match the recall period to the scale that it's supporting. And if it's a general impression of severity scale, then it would look quite general to be disease specific. But if it's concept specific, which the FDA has also been advocating for, particularly if you want to label or support a key secondary or primary endpoint, then I would look at a concept specific anchor. But nevertheless, main point being, in addition to a change anchor, I would include a severity anchor.
But you have,
Pardon?
Time points, your severity. Or are you doing it?
You would match the frequency of the instrument it's supporting. So if it's baseline and let's say a particular time point, then I would do both, because then you'll be able to look at that directionality. And then, I realize there's limitations to the anchor methodology, but I think unfortunately primary anchor supported by distribution based, we likely won't move away from that, at least from a regulatory perspective. But
I just wanted to follow up with the ECDF piece that you had talked about. I was going to suggest that, and if you look, we published this with Promise Fatigue in last year in RA, using ECDF curves to display the different anchor-based groups on a cumulative distribution function curve, and you really can see the nice dispersion with that. It allows you to, you really do see every individual patient. And I agree. I really am becoming a big advocate, actually, of looking at trial data in that way, because I think, and again, it lets you set your threshold wherever you want to along the scale, and you can see differences between treatment. And that's ultimately, what you need is, in a placebo-controlled trial or a control trial of some type, you want to see if there's a difference in this magnitude of change between treatment groups.
Okay. Can I just add to, sorry. To what you said, because I'm not sure whether you are actually suggesting that, but if you do state instead of change, ask the patient, how bad are you today or how good are you today? That you just calculate the change from what they said at baseline at follow-up and use that calculation to infer an important change rather than asking the patient, because asking the patient about change is well known, from the literature, is heavily loaded toward the current situation because they don't recall the previous situation so well. And when you just ask them at baseline and at 3 months or whatever the period is, then you can say, well, anyone who got 2 points better on that 5-point scale, we're going to say it's an important improvement rather than having the patient judge it. I'm not sure that that was what you're suggesting. If not, I would like to add that.
That's a great point, actually. Yeah.
This is just wonderful. And I'm going to get to that question in 1 second. I just wanted to open it up to anyone online to ask any questions or comments, either in chat or unmute and speak. And while you think about that, I'll just say that I think for this current study, we prioritized making sure we had patients from all over the world. So we kind of prioritized the study to make sure South Korea, Netherlands, Australia, everyone could participate. If I'm hearing correctly, it sounds like we should maybe generate additional data, but maybe just go a little deeper, because we sacrificed our depth of data for inclusivity. But it sounds like maybe if we just select maybe 1 or 2 sites and ask these additional questions of our patients longitudinally as being recommended, that might be a next best step. So that's just a question, and I'm waiting. Question, can we enrich for worsening patients? We tried to do that by trying to get new patients. The group that did that the best, to be honest, was the Netherlands. I think we were the worst in the United States because all our patients were kind of stable and they were the more stable patients. We can probably do better trying to enrich for new patients, but that is the next strategy.
I was just going to say, if you're going to try to get a few sites, specifically do more, then I would get the sites who have the most patients per country, because there's going to be variability from the standpoint of how the investigators interact with those patients. And if you have a patient here and there, that's going to generate more variability and noise than if you have, 2 sites where they have the most patients, and that's going to be more consistent for you.
Yeah, I think I support that it's a numbers issue. As I'm thinking about worsening, in some ways, where I think our group was always thinking about enrichment for new, I think the danger with that is that they actually probably, almost certainly with any treatment, will feel slightly better, probably by the next time that they're evaluated. So in some ways, new patient enrichment actually hurts us for that analysis. I'm wondering if it's a numbers game that you just include enough people or enrich them for more known severity phenotypes. We know which patients tend to fare worse by their antibody, for example. So in certain ways, we could maybe a priori try to guess or increase the numbers. But I think new patients for that analysis could backfire and create exactly the opposite of what we expected to do. At least in the US, I think we see that.
I have a regulatory question for your thoughts on it. I mean, I know you're not regulatory or your industry, but the context of use, I think, is an important thing too, right? The patients that are going to be entering clinical trials are going to be people who have high levels of symptoms and high levels of impact of their disease that's going to be measurable. You're not talking about an RA flare study where you have people that are in remission and you're looking for people to look at the amount of worsening. You are looking at a therapeutic study that is going to be in people that have high levels of symptoms, you're putting on treatment, and you're looking to see improvement. So that's your context of use. And the FDA is also very interested in, I think, as I read their qualification documents and have talked to people, interested in the data that you are delivering. You could use longitudinal observational data if the patients that are in your observational data set look like those patients who would be enrolling in a clinical trial. What's that? No, it's not, but I'm saying that in this consortium of patients that you have, you could start out with people that would have high levels of symptoms that are starting therapy and only look at those patients. That would mimic, and be very similar to what you would see in a clinical trial setting, in which case you really only care about the magnitude of improvement that's clinically meaningful. You don't care so much about that stuff that's on the other side, because that's not what your instrument is designed for. And that's also not what the context of use of your study would be. I don't know what your thoughts are about that.
I think it's an interesting point, and it probably easier said than done, right? I think it could be beneficial to kind of see what the inclusion exclusion criteria of trials is looking like, and try and represent in some way or form that population in the real world disease. But of course, that would exclude your comorbid populations and things like that. So it certainly could be one approach, but I think the other way I interpret the whole context of use bit is really about clinical meaningfulness and patient relevance of the measure and the evidence to support that. I view that term context of use more, this is representing the patient's experience with the disease. But of course, that aspect of it could potentially be used. In my experience, I haven't had any success or non-success with the approach that you mentioned. But having said that, I mean, it doesn't necessarily have to be impossible. I think it's a good idea to explore. But I think our biggest challenge in myositis will be gaining agreement on whether what we are measuring is relevant, because the regulators are not convinced that we are quite there yet. They may actually still not be convinced that every component of the IMAX total improvement score, for instance, is even clinically relevant and meaningful. So I think we may have to, as far as that context of use is concerned, I feel like that's how I interpreted it. How do we gain agreement that on what we even should be measuring? I probably answered your question only partially. Does that help?
I guess that goes back to, other comments about bringing the other existing IMAX core set outcomes into a full core set, not a kind of life impact core set. So that makes sense. And we had people obviously involved in IMAX listening in on a specific study group for outcome development. So hopefully they're hearing this, and this is going to hopefully spark some discussion.
Yeah, and I think it's the challenge with all composite measures, right? Are they all individually clinically meaningful and patient relevant? And then do they together capture the disease experience? And then does the weighting make sense? And where did that come from? So it's much easier to delineate the problems than I think it is to solve it.
TIS, the TIS has a lot of issues. Yeah. So I guess, Chris, I think we should go over the list of questions that we have in the time that we have remaining.
Sure. So we have about 7 minutes, and we had just a couple, thank you, questions that we threw in. I think we kind of answered the first one, to be honest, in terms of additional data that we need. We need more data, and we need more depth in terms of its granularity and some additional outcome measures that are monitored in each patient. We kind of touched upon this a little bit. The majority of our a priori hypotheses were not met. Is that cause for concern, or just kind of a single sentence to put into the discussion of a paper? Kind of wanted to get feedback on that process. My sense is I should ignore it, because here's, I don't want to speak for the working group, but here's my thought process on this. We sat down as a working group, patients, clinicians, researchers, and said, okay, what do we think the correlation is going to be? And we basically said moderate for all of them, and some were moderate, but the majority were small. To me, the fact that we got the majority wrong just reflects that we just didn't know as clinicians, as researchers, what the correlation was going to be. So why does I'm struggling to understand the significance of it.
No, I mean, if that were the case, you didn't know, your null hypothesis should have been 0 and not moderate. So you were expecting something on the base of unspecified a priori knowledge that suggested that it would be moderate. So you put your hypothesis, this is the whole idea of, putting your mouth where the money where your mouth is before you do the study, because all these, historical validation studies came up with some results, and then the discussion said, well, this is not so bad because blah blah blah, etc. And now you say, I'm putting my money on a moderate correlation, and if that correlation doesn't turn up, I think you have a problem with your expectation of this measure, and you have to do an additional study to solve the problem. If you ignore the whole thing, then you shouldn't have put up any hypothesis in the first place. Sorry to be strict.
No. I appreciate that. That's very helpful, but it's just, well, I'll let other comment. I mean, what's the study? What should be the next step of that study?
What kind of hypothesis it is, good or bad? Maybe you're just bad at postulating hypotheses, but you are a good investigator, So there will always be different hypotheses, and just to mandate the presence of one, I think is,
Well, there goes 10,000 years of scientific inquiry.
I mean,
Thank you. So another thing might be that when you're correlating change scores, like you have 2 change scores that you're correlating, so that's going to attenuate your correlations because you've got a little bit more error. So that might be something to think about next time. And I was wondering, in your chart of when you decided upon the hypotheses, there were a couple, and I was just wondering if they were related, because manual muscle testing, you really only got about 60% of the people saying that they agreed with that. So that might be another thing, like on the ones where there was 67% for manual muscle testing, physician global. Did that have any bearing on the ones that passed or didn't pass your threshold? But
yeah. I mean, I guess I was just chalking it up to, we all are bringing our own bias into this hypothesis generation, and that is informing us that we're wrong. So
I think the other thing, if you do this again, in terms of your hypotheses, it's always good to have things that you really know are not going to be correlated with each other. And you can easily hypothesize that those things are going to have, small, negligible contributions. And you don't really have anything here that you would hypothesize is not going to be correlated in some way. So that's one thing in a lot of these things that you would do, if you were measuring, I don't know, anxiety along with it, or you were measuring sleep or something else where you would expect that the correlations would be much lower. That's another consideration.
way of getting a very high correlation to put the extremes in, and don't put all your eggs in the moderate basket.
So in your last 90 seconds, can you tell 2 things is, what do you think you might throw overboard if you're going to do some reduction, and what are your next steps? You don't have to throw anything overboard, but
I mean, I think coming into this, we thought we were approaching the finish line in terms of some of these measures, and that we were going to, incorporate them.
That's an hypothesis.
Not the hypothesis, not the hypothesis. But we're going to, incorporate some of these PROs into clinical trials and see how they perform, and that's going to happen regardless. I think, what we're taking away, at least one thing, is to obtain more data on a deeper level, maybe just a few sites, incorporating some of these measures of severity that have been brought up, some different analytical methods, and looking at meaningful change, and maybe rethinking about the correlation hypotheses.
Years period of sense. Exactly. So that was Bing's suggestion. I strongly support that. So you don't have to wait for the trials.
And I think the other thing, just to leave with that, we really were hoping that we could maybe just continue on our path is the synergy, because we think we are synergistic, or we didn't want to be repetitive with IMAX, but I think we'll take away this idea that to your point, that we have a life impact prom and maybe we need a true course set that fine. I don't think we were dueling. I thought we were staying in our lane.
And Chris, a
What's this-
couple last questions, if you
Oh,
wanted.
I mean, I don't perfect. No. There we go. Any final questions? Thank you everyone for coming. I really appreciate all the effort. Wonderful.
Pearson, maybe I should have. I looked at the distribution.
Yeah. But it's the whole correlation concept. It's nice because it uses the whole scale and you're getting more information in there, but then you're also having your worsening people in there now.
Yeah,
So
I appreciate you.
that much more data collection. That's what I'm struggling. Well, I think the serial state, that's what I call this idea. Instead of asking just an anchor change, ask T1, T2 of that state.
Like you said, exactly.
And then we went to patients and said, in T1, T2, if you had a 1 point change,
Yeah.
you saw this, would that be an important change?
Mm-hmm.
And then, so it's not just assuming that.
They directly asking.
Yeah, and then with the change score, I would also tag that on. So here's, you said you're better. I might say, the time two, I'm a little bit better. Is that important to you? Like, because they'll have to say, oh, no, it's not.
All right, yeah. Directly asking them if they think this is a
meaningful change.
Yeah.
Can I ask a question? Can you hear me?
Yeah. So for all your contributions.
You guys have done amazing work.
Yeah. Thank you. Yeah. So in terms of the TIS work, so TIS is something that I'm working on, and I just published the work on the TIS, the validation of the TIS. I don't know if you've seen that validation of the TIS and reported changes in that. Yes, exactly. So all the whole TIS work is at the ACR, also the recently published one. And I'm working on, so right now what will come out next is the patients who achieve improvement, at least minimal improvement per TIS, are they also experiencing improvement in their pain, fatigue, quality of life, etc.? So we have that data analyzed. The paper is ready. Exactly. So my work basically is with overlap. This one is mainly the PR.
Can you hear me?
We're lacking. So right now the
Can you ask if the way to look at worsening is to do a study on flare?
What they are using is, for example, Promise 29. It has been validated. It hasn't been.
Look on the chat. Look on the chat. Look on the
Has much data. And also Promise 20 is I also my paper. So,
I thought I saw
Yeah.
your name on that paper.
exactly.
Isn't that
I'm
the one
first on
from
the
2020? The first, yeah, your first on.
Exactly.
Yep, your name is
So
in my
that's a
file.
promise 20, but the only thing that with the promise 20 is that doesn't have contact validity. So we didn't go to the patients at the time and
Yeah,
ask
yeah.
if these are relevant. But for these promise instruments, we did. That started the
I'll call.
asking patients, is this feasible? Is this relevant, etc.
You know what happened with the IMAX, I think? In that panel, there was only like one patient
Yeah, and that was,
in that methods paper way back when.
yes, it was like,
Yeah, yeah.
I'm trying to remember 20.
Which I
Yeah.
also understand because it's a rare disease. But that could be.
Dana, can you hear us?
And also the
Hi,
component
can you
of
hear
the
us?
CIS, so the
Oh,
head
you
has never been shown to have contact validity. in
you took,
themselves, right? And when we
you
did
took,
the
you took your
we
earphone.
showed
Can you hear
patients
us?
That have questions like brushing your
Hi.
teeth.
So-
etc. So the myositis is
What, so what,
proximal weakness.
sorry, my question
Going back
is,
to Bing's question might be really
yeah,
relevant.
She wouldn't have
Do you
issues with
need
brushing.
to look at worsening?
Relevancy issues. with
Um,
that.
Like
right.
have a group that you want to be able to look at worsening or improvement. But if everything's aiming towards improvement, you might want to focus on that and then make sure you've got some other indicators to pick up harm.
Yeah,
that people
no, I
got
completely
worse.
agree. And within the context and
doing
context
this
of
in
use,
order.
and this
Hear
is
you.
why it's, oh, okay. Sorry. Okay. Okay.
Can you try again? We
Can you
can't-
hear me now? Can you hear me?
Oh, yeah.
Here,
Okay.
the issues with trying.
Now I can hear you.
All I wanted to know, just because we have all these, minds in one place.
Yeah.
So if we were forced to look at the worsening group, if we were forced to do that in terms of looking for a population or a design to do that, would it be, can you do a study just for flare?
I like this drawing.
That might do it. If the flare concept is the same as getting worse.
Because how else, what else would be a population of people who are getting
Well,
worse?
that's
It's
why it
flare,
might be
yeah.
a small group and it's very noisy. The data is not stable. They weren't all getting worse. They were going up and down. And so it might be that worsening, according to this global, is not picking up the same thing that improvement is, which was a bit
Right.
more uniform. You know,
Yeah.
those serial states that they're talking about, T1, T2,
Mhm.
a serial state, measure of a severity at time 1 and at time 2, and then subtracting those and using that as an anchor,
Yeah.
that might pick up some of the worsening a little bit better. It might. So that
Yeah.
would be a bit more in another trial.
Okay. We'll play around with it. Thank
Yeah.
you.
And the ECDF stuff, all that, like just looking at the data, looking at the people that are worse and see what they look like. Are they all at the ceiling? Oh, okay. Hang on. Just somebody wants to say hi.